I thank the chairpersons and the speakers for an informative session. Let's move on to the next session of Thyroid Symposium on Thyroid Clinics. I invite the chairpersons, Dr. Narayanan NK, Consultant Endocrinologist, Apollo Hospitals, Chennai. He has research experience at Cambridge University, UK. He has multiple publications and written many book chapters. I also invite Dr. Dalapati Sadachandran, Associate Professor, Department of Endocrine Surgery from MMC. He was awarded as the Best Resident Award at SGPGIMS. He is the first MCH qualified endocrine surgeon in Tamil Nadu. He is the elected member of Tamil Nadu Medical Council. He has multiple publications and has written many book chapters. I request the chairperson to introduce the speakers and take over the session.
ನನ್ನ ನೇಮ್ ಶೇರ್ ಮಾಡ್ಸೋದು.
Dr. Dalapati, you there to introduce? Yeah. Hello.
Hello.
Dr. Dalapati? Okay, we'll proceed.
Hello?
Yeah, please. Yes, please go on.
Thank you, Honorable. It's happy to introduce Professor Nihal Thomas. He's the former Deputy Medical Superintendent and Director of CMC Vellore, and he has a lot of publications, more than 250 indexed publications, and his areas of research include a lot of pathogenesis of diabetes in India, and a lot of his work related to diabetes he has done. He has been awarded numerous citations and awards as well as medals. He has has been awarded an outstanding researcher in 2009. And next we would like to ask Professor Nihal Thomas to go ahead with this talk.
Thank you, Professor Dalapati. It's wonderful to be over here today. And thank you, Dr. Vijay Bhaskar, and all the other organizers for organizing this wonderful meeting. So my topic is controversies in the management of differentiated thyroid cancer. And I think from a perspective of both endocrinology as well as endocrine surgery, this is a really interesting area, particularly since there's a lot of overlap between the guidelines of various bodies as far as endocrine cancer, thyroid malignancies are concerned. So just a little primer. Thyroid carcinoma consists about 1% of all malignancies. The prognosis for thyroid cancer is one of the best amongst all malignancies, goes without saying. And the current spectrum of accessory care is fairly impressive. If you go back about 2.5 to 3 decades, there was virtually nothing beyond thyroxine suppression treatment after surgery and radioactive iodine. But now surgical skills, techniques, and a lot of other things have come in place. So we have pre- and post-operative ultrasound surveillance, thyroglobulin measurements, recombinant TSH therapy, positron emission tomography. Molecular diagnostics have now come on and play a big role in terms of stratifying the prognosis. But have we got the basics in treatment right? There is a lot of heterogeneity. So the guidelines are not rules. They are recommendations. They are reviews of current literature, and they are relevant to individual cases and do not extend into real-time management. So there are a number of guidelines, and of course, there are, as you can see over here, 3 American-based guidelines, as well as the British Thyroid Association guidelines, and there are differences. I'm going to be focusing largely on the American Thyroid Association guidelines of 2016. I will also intersperse some clinical cases in addition. And you can see over here that it's quite clear that over the last 3 decades, that the incidence of thyroid cancer has increased. And is this a true increase? Well, goes without saying that perhaps is a little bit of that. But beyond that, we are doing a lot of imaging modalities, ultrasounds, etc. An increase in early thyroid cancer in particular, and also a fair amount of subclinical diseases being detected at this point of time. So if you look at the age standardized incidence, there is certainly an increase in incidence, which has gone up very much, extremely significantly. Having said that, when we match it with age standardized mortality, there really isn't much of a change. It's been more or less the same, perhaps, in fact, marginally a little better. This is an interesting publication which came about a decade and a half back. And this tells you about a putative increase in female mortality due to thyroid cancer. There are certain biases in this particular study, but that was an interesting trend in that particular population which was noted. Now, so the points for discussion include our current management policy, tumors to excise or not to excise, prognostic predictability of histopathology, the role of routine postoperative radioactive iodine therapy, and some thoughts on future directions. So let me just start with a bit of the recent advances as far as thyroid malignancy management is concerned, because there is certainly a bit of a mismatch. Even when you look at the 2016 guidelines, the emphasis on molecular diagnostics, etc., are left behind. Even from a surgical perspective, and I'm sure Dalapati will agree with me, there is a bit of a mismatch over there. And I guess these guidelines are thrown open to a broader world and may fall short of the expectations of an endocrine surgeon who's at it day in and day out as well. So the molecular adjuncts are really important now, and they have made a difference in quaternary care in centers of people who actually understand this. The gene expression classifier, there are a 7-gene panel of somatic mutations and gene arrangements, and there's a 60-gene NGS panel, which can, within a week or so, give you the results in terms of stratifying a malignancy when you're looking at tissue of thyroid malignancy. And the combination of somatic gene panel with Mirna levels is also important. So also the Mirna only panel. Now, the commonly used gene expression classifier is the AFIRMA. And over here, as you know, when we look at thyroid FNACs, we divide them into non-diagnostic, benign, indeterminate, suspicious, and malignant. So there's no problem at either end of the extreme ends of the spectrum. The benign, follow up closely, and of course, the risk of malignancy is less than 5%. Malignant, truly malignant on an FNAC, lobectomy and total thyroid bath or total thyroidectomy, depending on what I'm going to be telling you shortly, because the risk of malignancy is more than 40%. But the one in between, the center, indeterminate, is where you actually use the AFIRMA thyroid FNAC analysis. And this can really make a difference in terms of giving you a guideline to which direction you should be going. The molecular adjuncts are something which is going to evolve over time, but particularly I would like to highlight the TERT, the telomerase reverse transcriptase, which along with the BRAF V600E are important markers. And if you have a combination of these, it's associated with a poor prognosis as far as a differentiated thyroid malignancy, namely largely papillary thyroid cancer, is concerned. So it's best to choose a test which is tailor-made, and in-house developed tests may in fact serve the purpose. It's good to have your own lab when you're an endocrinologist or an endocrine surgeon and work with the lab together to make these decisions. So this is a publication which my colleagues in endocrine surgery, the molecular pathology department, and us work together on, and it shows that 24% of PTC positive have the V600E mutation, and the BRAF positive cases are significantly associated with lymph node metastasis and extrathyroidal extension, both of which are much more when you have the BRAF positivity. The active surveillance has been proposed by the Japanese. 2016 guidelines have it. Less than 1 centimeter nodules, no extrathyroidal extension, and no history of irradiation. So the extent of surgery has been defined by the different categories: the American Thyroid Association, the British, the National Cancer Body in the US, and the endocrinologists of America as well in addition. And you can see over here that they are more or less the same. If they're less than 4 centimeters, no familial disease, or it's unifocal, you tend to be more conservative, and you can go ahead with thinking about hemithyroidectomy. And I think most endocrine surgeons would go in this particular direction. It's of course related so much to expertise. If someone is a general surgeon who does probably about 4 or 5 thyroidectomies in 6 months, perhaps that would be different at how they might actually look at the whole thing. But an endocrine surgeon who can actually carve out a good dissection would make a very big difference, and these guidelines hold at best over here. What are the target TSH levels after thyroidectomy that you'd like to have? So there are subtle differences between the guidelines. The American Thyroid Association keeps it as an excellent response from 0.5 to 2 units per liter, and the British at 0.3 to 2. And the National Cancer Corporation does not actually have a clear guideline as far as this is concerned. Now, when we talk about thyroglobulin measurements, we talk about as to whether they should be stimulated, as in the thyroxine therapy is stopped and the TSH is elevated, therefore the thyroglobulin is stimulated, or not. Now, new assays are more highly sensitive, and the claim is therefore that we need not do a stimulated thyroglobulin level. You can just check the thyroglobulin straight away. They have a higher negative predictive value, and therefore stimulation may not be needed. I'm not so certain as to whether we have reached that degree of precision over here. I think we really need to understand the significance of the disease and measure them, but I'm sure chairpersons also may have an opinion on this in addition. After hemithyroidectomy, now there is a cutoff for thyroglobulin measurements of less than 30 nanograms per ml. So those are the fairly recent concepts of the last 4 or 5 years. And I'm going to come to these questions which come again and again and again for the last couple of decades. The management of differentiated thyroid cancer involves total thyroidectomy with neck dissection, except for a lesion which is less than 1 centimeter in size. Achieve hypothyroid state for 6 weeks. Radioactive iodine 30 to 100 millicuries. Follow up once in 6 months with I131 scan and serum thyroglobulin levels. And step 5, suppression of TSH with supraphysiological thyroxine lifelong. So the tumor to excise or not to excise? Well, going by the ADA evidence base, we have ranging from A, strong recommendations based on reasonably good studies with well-designed prospective analysis, down to B, wherein the recommendations are a little weaker but good enough. And then you have the intermediate recommendations, and then you have expert-based opinion as in C and D, and right down to the bottom where they're ambiguous, neither for nor against as in I. So how much of tumor or thyroid should we excise? I'm going through this exercise because I think we need to remind ourselves again and again, based on the expertise available over here, the ATA guidelines to remove primary tumor, disease that is extended beyond the thyroid capsule and involved cervical lymph nodes. Now, surgical options include lobectomy, near total thyroidectomy, but does not include subtotal thyroidectomy. That is out of the window. We have stopped. It should not be done. Isolated interpolate thyroid nodule, limited surgery, evidence base C. Thyroid nodule more than 4 centimeters, bilateral nodules, marked histological atopsia, family history, previous RT, no doubt, total thyroidectomy, and there is strong evidence base A for this. We have no doubts about this. So routine central compartment level 6 for papillary thyroid cancer and Hürtel cell carcinoma, near total with central compartment dissection for follicular carcinoma. Not bad, evidence base B over here. So the current common practice, remove tumor disease that extended beyond the thyroid capsule and involves cervical lymph nodes and perform a total thyroidectomy. So for the proposition, high incidence of microscopic multifocal disease, facilitated radioactive iodine treatment. If you want to give radioactive treatment, you need to have minimal amount of thyroid tissue hanging around the place. And then we can use thyroglobulin more reliably as a marker for recurrent disease. Of course, the later generations of thyroglobulin measurements, you might argue against this. Possibility of anaplastic transformation of any microscopic foci of carcinoma, but of course that is extremely rare, even in the realms of an experienced endocrine surgeon or experienced endocrinologist. It's not that common, but of course it can happen over many years of follow-up. How much thyroid tumor should be excised? Once again, as far as a limited excision is concerned for the proposition, benefits of total thyroidectomy in low-risk patients is small, with an added risk of permanent hypoparathyroidism. Now, in the best of hands with good endocrine surgeons, I'm sure this comes down much lower to levels of less than 2 and less than 1%. So I don't think this holds good for a good endocrine surgeon. And I'm one of our chairpersons is over here is very much in that realm. External laryngeal nerve damage should not once again happen with such great frequency. But I think for the broader part of the country and perhaps the world in developing countries, this to some extent may hold good. And of course, many surgeons outside the endocrine surgery realm don't even think about the external laryngeal nerve. So limited thyroid resection may avoid lifelong thyroid hormone replacement. The presence of microscopic multifocal disease has little clinical importance, with low incidence of recurrence in the residual tissue. And of course, as I mentioned, anaplastic change in thyroid cancer is an extremely rare phenomenon. So when we come to limited excision, 75% lie in the low risk group. The recurrent rates are about 5%, and the survival is pretty good, 98%. And these have been backed up with studies which are now fairly old, actually speaking. Okay, now the prognostic predictability of histopathology. I think anyone from the level of a medical student can tell very clearly that this is what you're looking at, papillary thyroid cancer on the left-hand side. And over here, you can see the invasive disease reaching the capsule over here, as in this case, over here. So we look at the two studies which have looked at the prognosis as far as histopathology, but there are certain flaws. Fertile cell tumors had been categorized under follicular lesions of their poorer outcome. Now, when you have a histological misclassification plus a misdiagnosis, it will equal worse prognosis. As far as tall cell variants of papillary thyroid cancer, the ATA defines this as an aggressive histological variant. And the traditional article citing this tall cell variant having a poorer prognosis is way back once again about 26 years. There is another study which has shown that tall cell variants have a better prognosis if they have accompanying lymphocytic infiltration, which indicates that there's an immune reaction which is going to be perverse for the presence of cancer related cells. The relevance of nodal metastasis in papillary thyroid cancer, therefore, lymph nodes not regarded as unfavorable, high association of nodal metastasis in younger patients. So there are studies which have shown that when you have in older patients, the thyroid cancer may be a more unfavorable prognostic factor, whereas in younger patients, it may be a more favorable factor. But these are, of course, from diverse studies with different methodologies, and they may have their own flaws. Okay, so when we come to differentiated thyroid cancer, I'm going to come up with a few examples here. Diagnosis and personalized treatment is so important. So here is a case which the team of endocrinologists, the endocrine surgeons, my colleagues, and the nuclear medicine people have actually handled. And I think this multidisciplinary treatment is so very important for handling complicated thyroid cancers. So here you can see the tracheal shift on the X-ray. This patient came with a large mass in the neck, and you can see over here it is very invasive, the erosions of the thyroid cartilage and local extension as well over here. So the CT scan indicating loss of fat plane with the esophagus and with an internal jugular vein thrombus also seen in addition. So yeah, you can see once again the internal jugular vein thrombus at the subclavian confluence. So this patient obviously required a total thyroidectomy. There is no doubt as far as that is concerned, and had a neck dissection for removal of the lymph nodes in addition. So now what has actually come into play, which we would not have thought about more than a decade and a half back, is utilizing the presence of chemotherapy. So the medical oncologist does have a role in some of these invasive malignancies, and adjuvant radiotherapy with weekly paclitaxel was given for this patient. So that is an example of the newer role of radiation associated and along with chemotherapy. Okay. Now, the role of routine post-operative radioiodine treatment. What is the role of routine post-operative radioactive iodine ablation in differentiated thyroid cancer? So radioactive iodine is recommended in stage 3 and 4, all stage 2 less than 45, and most stage 2 more than 45 years. Now here we become a bit vague. Selected patients with stage 1, particularly multifocal, nodal metastasis, extrathyroidal, and vascular invasion. And therefore the evidence down there is evidence B. So the common practice is following total thyroidectomy, do a I131 scan, and then followed by ablative radioactive iodine, repeat scan, and thyroglobulin after 6 months. And the acceptance of radioactive iodine treatment in the guidelines in USA is about 61%. So even in developed countries, the acceptance rate for radioactive iodine therapy is not
So the doctor lost the internet connectivity. I think he will rejoin in a few minutes, so we can have some small discussion or answer questions.
So we also have
the chairpersons can have some panel discussion, have some discussion on the topic till Professor Nehal Thomas joins.
Actually, there was a question in the chat. How long the patient has to be followed with the radioiodine scan? The TG is less than 0.5. That was the question from Dr. Narayanan. Actually, Dr.
Sorry, my internet got cut in between.
Okay.
I'll just re-upload my slides. So sorry.
Sure.
Have my slides come on?
Yes, sir. They come on, not in PowerPoint mode, sir.
Sure. I'll do that. Yeah, I'm so sorry about that glitch. Can you hear me now?
Yes, sir.
Yep.
Yes, sir. Please go ahead, sir.
So post-operative radioactive ablation, the decision to do a total type cannot be disconnected from the necessity for radioactive iodine. That plan of action has to be there in mind. And of course, there have been arguments against the proposition for some patients with low-risk disease. And of course, you need to be aware of the fact that some metastases do not concentrate radioactive iodine. Now, with patients with low-risk differentiated cancer who have a good prognosis, we need to bear in mind the role of total thyroidectomy for this as the first line of treatment is underestimated, as 46% were found to have a tumor in the contralateral lobe as well. And this is once again the reason why the remnant tissue we do consider radioactive iodine treatment. Having said that, a drop in thyroglobulin levels indicates that things have improved, and therefore you may not need to keep scanning thereafter. Now, here is an example, another 23-year-old female who's got papillary thyroid cancer, and you can see the extent that she has with evidence of metastasis. And if you see this kind of black lung, I mean, if someone who is not familiar with treating thyroid cancer, they think with this kind of isotope, that's it. The long-term morbidity and mortality is going to be not going to be great. But of course, we who have had experience with this, you can see the high TG levels, the increased uptake, and you go ahead with ablating this patient repeatedly. And with repeated ablations, you can see that the I131 scan has shown a significant remission of the disease, and the thyroglobulin levels also have dropped dramatically. Now, unlike the recommended dose of 200 millicuries for lung metastasis, this patient received a cumulative dose of almost 300 millicuries. So it's not all one size fits all. You need to be specific. You need to actually make allowance for giving individualized treatment for these patients. Here's another one, 13-year-old male with noisy breathing in the year 2010, had a hard mass in the neck with multiple nodes, and you can see had a lymphadenectomy outside and a total thyroidectomy, and was symptom-free. Then came to us with a recurrence, needed a sternotomy with a lot of infiltrating of the trachea, and needed a complete resection, and also had local radiation to the neck. The patient needed cumulative radioactive iodine treatment. Now here you can see once again, very invasive disease, but you can see the thyroglobulin levels. The uptake is not as impressive as the previous one, but eventually over multiple dosing, over 5 years, and the thyroglobulin levels, which are not as impressively high as the other, see, they don't match always similarly, have also shown a decline, and the patient was doing well. Now here again, you can see a patient with multiple metastases, probably even bone metastasis, and it's important to remember that bone metastases do not respond as well to radioactive iodine treatment. That, I think, is something which we need to keep at the baseline when we are handling these patients. Nevertheless, there is some response, and you can see over here serially at the end of 4 years that there is some improvement. So when we talk about future directions, I'm going to once again present a case, and that tells us the state of the art at where we stand right now. 60-year-old lady, swelling the left side of the neck in the year 2007, lymph nodes, restricted mobility, a thyroid nodule 1 into 1 centimeter hard, and patient was euthyroid when he came. And you can see over here the ultrasound showing this large lesion along with lymph nodes, and this is the extent of the disease. So this is an infiltrating tumor, as you can see from the ultrasound, and it infiltrates the central compartment and a large left cervical lymph node. So the histopathology showed papillary thyroid cancer with Hashimoto's, and the tumor site was 3 centimeters with extrathyroidal extension. Now there was metastatic, at the time of surgery, there was metastatic carcinoma in 4 out of 10 central neck nodes and 3 out of 20 left lateral nodes. So here, once again, I131 scan has been done, but it is negative from what you can see over here. A SPECT has been done. Now, despite the fact that the patient has a low thyroglobulin and a relatively poor uptake elsewhere, but a little bit in the bed, ablation was given with 50 millicuries empirically for this patient. Once again, thyroid scan negative and stimulated TG 0.2. You might argue and say, well, should we give? There's one argument which says, once you give, you can do a scan after ablating and see whether there's an uptake. But that wasn't the case over here either. So here is the follow-up of the patient over a period of time. TGs were low, and subsequently some rise in thyroglobulin levels. And here is basically a patient who has elevated thyroglobulin, but iodine scan negative. That is what we call tennis. So here 37, not as impressively high as the previous patients, but nevertheless increasing. So there is, in terms of the baseline value, an exponential increase. A re-excision was done in this patient, and then bilateral subcentremic cervical lymph nodes were found on the neck at this point of time, but Patient was kept on conservative management. Then an X-ray shows a lesion in the lung, a small lesion, and a CT-guided biopsy was done, and this shows lung tissue over here, along with the papillary, typical papillary appearance within the lung. So this is stains thyroglobulin positive, the papillary frowns, and thyroglobulin staining positive. So that is the appearance of the patient. So what do we do for this? Low TGs which are not too high, I131 negative, lung metastasis. So we have a discussion and we have the option of radiofrequency ablation versus tyrosine kinase inhibitors. So this is what we do. The patient has been given radiofrequency ablation. And that's the PET CT. And subsequently, you can see the area which is necrosed after radiofrequency ablation in this patient. So, yes. And the patient is also on follow-up now. And subsequently, what we decided, we'd give tyrosine kinase inhibitors. And this has been done to this patient. And even to this day, that is, I think, about 6 months back, this patient is on follow-up and doing pretty well. So what are the future directions? Number one, sort of the basics. We need prospective studies with randomization to variable types of surgery and radioactive iodine. We need a detailed analysis of histological subtypes, study of environmental factors that may influence thyroid cancer, and enable more widespread usage of molecular diagnostic markers. I'd like to thank all my colleagues from endocrinology, endocrine surgery, and nuclear medicine for being supportive over the years. And a lot of this is indeed teamwork. Thank you for your patient listening.
It's an excellent presentation, Professor Nehal Thomas. Due to shortage of time, we'll be taking only 1 or 2 questions. My question is actually, what is the role of lobectomy in case of papillary thyroid cancer, especially in case of micropapillary cancer, and the role of iodine 131 in case of incidentally detected microcarcinoma of papillary microcarcinoma?
Yeah. Thank you so much for that very relevant question. So I think what we follow in CMC follow is much akin to what you follow in Chennai at this point of time. So if, in fact, we have a discussion with the patient and we give them the option that if it is only a microcarcinoma which does not look sinister and is unilateral on an ultrasound, we can actually follow up if it's a low-risk patient. So that is one option. The other thing that we do for these patients, if they are in the higher risk group and it's unilateral, we will offer them a lobectomy and we tell them that we can follow up these cases. Sometimes patients get cold feet and they will say, I would like a total thyroidectomy. So I think it's a decision which we make with the patient most often, but we very often tell them that a more conservative approach would be appropriate away. And that's what our endocrine surgeons would actually like to do. As far as microcarcinoma is concerned, we do not advocate if it is unilateral, localized, we do not recommend radioactive iodine treatment at this point of time. We'd follow up the patient with thyroglobulin levels and we'd like to see what happens to them eventually. But sometimes you may have, for example, a patient may have a particular surgery, the thyroidectomy is done, and you may find an incidental microcarcinoma. And that kind of patient, really speaking, is in the lowest risk of category.
Another question from audience is the role of chemotherapy in thyroid cancer, sir.
So this is something which is coming into play right now, more over the last 5 to 10 years. And as I cited over here, we had a patient who had paclitaxel therapy along with radiation. So if you have more invasive disease beyond the realms of a normal radiation field, you could, and particularly if the thyroglobulin levels are low and you could not achieve a proper excision of the tumor, and of course, these patients are not good options for radioactive iodine treatment because you have residual tissue in the neck, plus the fact that the thyroglobulin levels are low. Here you would give a combination of external beam radiotherapy plus chemotherapy for these patients. The other thing is, of course, when you have recurrences and they are becoming, showing tends towards dedifferentiation or anaplasia, then you would consider chemotherapy as a therapeutic measure.
Thank you for your excellent presentation, sir. And
thank you so much, sir.
For your answering. And thank you, sir. Thank you once again. Dr. Narayanan?
Yeah. So good evening, everybody. With that, we will move on to the next session for this evening, clinical snippets in thyroid from the veteran's life. So it gives me a great pleasure to introduce Professor Mark Gunnell, Professor of Clinical Endocrinology in the University of Cambridge. He wears many hats. He's a clinician par excellence, an avid researcher who has got many international publications, a highly sought after speaker at many international forums. And I'm sure many of the audience here would have listened to him before. We invite Professor Mark Gunnell to give his talk on clinical snippets in thyroidology.
So Narayanan, thank you very much to you and actually to all the organizing committee for the very kind invitation to join. I really would like to be with you there in person. I've had some excellent trips previously, and I look forward to when we can get back to doing those kind of face-to-face meetings again. But anyway, we will proceed because clinical practice goes on. I'll just check that everybody is able to see the slides okay.
Yes.
Perfect, thank you. So what we're going to do in the next 30 minutes or so is we're going to look at some clinical cases, which I think illustrate some really important learning points into how to approach patients who've got unusual, if you like, atypical thyroid function tests. And this is an area which is of particular interest to the team here in Cambridge. And actually we have lots of collaborations with colleagues over in various locations in India who kindly share cases with us. And many of these illustrate some really important points about basic physiology, biochemistry, and also about understanding really how the endocrine laboratory works as well. So when we encounter problems with the interpretation of thyroid function tests, it's important to go back and just bear in mind where those issues might be arising. And that could be actually even before the sample actually reaches the laboratory. It may be that we've already created a setting or a paradigm which is going to cause a confusing result. So for example, if we haven't taken appropriate account of the age of the individual, if the patient's pregnant, patients on thyroxine therapy or other confounding medications, or could have non-thyroidal illness, these can also change the pattern of results we're expecting to see. People will know from talks I've given previously that, of course, the laboratory is crucial here. And so if we don't recognize some of the limitations of commonly used assays, that can cause confusion because assay interference from one of many different types can produce results which are perhaps not genuine, true results. And if we act on those, we may end up mismanaging the patient. And then there are the fact that there are some rare conditions that affect the axes that many clinicians may have limited experience of dealing with. And these could be genetic or they might be acquired. And in particular, the areas that we have an interest in, which cause, for example, high thyroid hormone levels with non-suppressed TSH, we have to think about rare conditions like resistance to thyroid hormone, disorders of thyroid hormone transport metabolism, and also rare TSH secreting pituitary adenomas. So when it comes to dealing what I sometimes refer to as the anomalous TFTs, but you may have heard them spoken about as confusing, discordant, funny, perplexing, puzzling, unusual, whatever the word is you want to choose, actually most of these distill down to one of two meanings in terms of broad categories. Either TFTs which are discordant with the clinical picture, so the patient in front of you, for example, is hypo or hyperthyroid, and yet the thyroid function tests are telling you something different. Or alternatively, thyroid function tests which simply don't agree with each other. And so then we have to try and reconcile those and work out which is the true result and telling us the right information and why the results discordant with each other. And again, just taking you back, there are some very basic principles that we need to hold in mind if we're going to actually sort out these unusual or confusing anomalous TFTs. So we'll briefly just remind ourselves about those factors that govern thyroid hormone synthesis, secretion, transport, uptake, action, and metabolism. We'll touch on some of the underlying principles for measurement of T4, T3, and TSH in the laboratory. And then we'll also consider pattern recognition of conditions which produce unusual thyroid function test results. So again, forgive me for an expert audience, I'm going back to something which I'm sure is very familiar to all of us, but it is useful just to remind ourselves about different parts of regulation of thyroid hormone physiology in order to understand some of the conditions we're going to briefly discuss. So it's a classical feedback negative loop in terms of the axis, hypothalamic TRH and negatively somatostatin regulating pituitary TSH production, which of course regulates production of T3, T4, approximately 14-1 in favor of T4 over T3. And then we have a negative feedback loop with T3 in particular inhibiting both TRH and TSH production. Of course, once that thyroid hormone is released from the gland, it needs to get to the target tissues, and it does that bound to one of three different proteins: thyroxine binding globulin, but also albumin, and then what we used to refer to as prealbumin, but probably better referred to as transthyretin. And these are critically important, of course, because as you know, more than 99% of thyroid hormone is transported in the system bound and therefore not freely available until, of course, you get to the target tissues where the free hormone is released. Again, when we think about the cells in those target tissues which are responding to thyroid hormone, T4 and T3 entering the cell, remembering now that, of course, we know there are various thyroid hormone transporters which are facilitating this process. For example, in the central nervous system, this critically important transporter, monocarboxylate transporter 8, which is facilitating, for example, T3 uptake. If you've got T4 uptake, of course, T4 being converted to T3 by one of three members of the deiodinase family. And then T3 itself entering the nucleus of the target cell, interacting with the nuclear receptor, the thyroid receptor, which then is essentially a transcription factor, recruiting a whole family of other transcriptional regulators to direct transcription. Here we've got a positively regulated gene, but equally it could be a negatively regulated target gene. So this is a really complicated system, but is very finely tuned to optimize exposure and action of thyroid hormones. Whoops, so Daisy, we seem to have just apologized for that. We'll just move on. I seem to just have an interesting development in the slides. Hopefully we'll get past that. Here we go. So moving on here, the next thing I would like you to take away, and in fact, in some ways, this is almost the single most important slide I'm going to show you this afternoon or this evening in local time. These abnormal patterns of TFTs are really, really important to recognize. If you absolutely get stuck with sorting out a case, if nothing else, and you go back to this simple algorithm, you'll be able to pick up most of the diagnosis of these complex disorders. So thyroid function tests classically fall into a group of different patterns. There are those which are very familiar to us, ranging from the classical thyrotoxic with raised hormones, suppressed TSH, to those who have low thyroid hormones with raised TSH. And those are all concordant results. They're exactly what you would expect. But in addition, we can also find ourselves facing patients who've got unusual or anomalous TFTs. For example, the free thyroid hormone levels are normal, but the TSH is low, possibly even suppressed. Or the free thyroid hormone levels are normal, but the TSH is raised. And again, here are some examples of conditions familiar to us that can lie in each of those categories. We may, of course, encounter patients with thyroid hormone levels that are low, but the TSH has not gone up as we'd have expected it to do so, or free thyroid hormone levels that are raised, but the TSH isn't suppressed as it should do. And you can see there are quite a lot of conditions that can produce these patterns, some much more common than others. And it's, as I say, it's very useful to be able to go back to this reference point if you're faced with an individual with these unusual patterns. So what I'm now going to do is to build on that information and use some cases, patients all referred into the Cambridge service, either locally or from farther afield, all illustrating important points. So here's the first case. This is a 72-year-old man who was referred to me by a local primary care physician who had noticed that he had progressively rising TSH levels. Now, this gentleman was on long-term thyroxine therapy. He'd been on this for many, many years, and the GP was concerned as to what was going on because he couldn't understand why the TSH was systematically rising, as I'll show you in a moment. Primary hypothyroidism dated back to the mid-1990s on 125 to 150 micrograms a day with annual TSH monitoring. He also had some other pieces of information relevant in the past medical history. He had hypertension, aortic valve replacement on a combination of cardiac medications, as you can see there, but nothing else of note. Clinically, when he was seen, he was actually at this stage, by the time an assessment was made, with a fine resting tremor, a borderline near tachycardia, no palpable thyroid hair, and nothing else of note. But these were the blood results that GP and the primary care physician therefore was struggling with. We can see that the free T4, all results are going to be presented this way. Anything in gray is essentially within the reference range, and the reference range value is shown. Anything red is high, anything highlighted as blue is low. So you can see that this gentleman has a free T4 towards the upper end of the reference range with a TSH who is clearly significantly elevated. And when that was repeated, the results were still clearly abnormal, if anything, perhaps even slightly more abnormal in terms of the height of the TSH. So there was a little bit of exploration now of the historical thyroid function test documented in this patient's records. And you can see that for many years, the TSH had been pretty well controlled on a standard dose of thyroxine. But here are the two results which have triggered interest. And actually, you can see that the GP had actually endeavored here to adjust the thyroxine dose in the hope that this was actually going to improve the situation with the TSH. But the TSH was actually rising further. And by the end of this process, the free T4 was also actually now elevated and outside the upper limit of the reference range. So here you have a patient who at the end is with hyperthyroxinemia on thyroxine with a definitely non-suppressed raised TSH. So I'm just going to ask you all, just in your own heads, just to think a moment about what you think would be the most appropriate next step in the management of this patient. Do you think this is a case that the patient is not absorbing thyroxine properly, so we should do a thyroxine absorption test? Do you think we should check a free T3 level? Is it most important to discuss with the clinical laboratory? Should we increase thyroxine dosage further to 200 micrograms a day? Or should we think about requesting a pituitary MRI scan? Now, obviously, we're not going to take an audience poll on this, and I'm literally just asking people just to have a little think about this and to what they would personally do. Well, you don't have long, and obviously in practice, you'd have a little bit more time to reflect on this. But the correct answer here, and it's always the correct answer in this situation, is to actually discuss this with the clinical laboratory. Something is not right here. This is a man who's normally well controlled on this dose of thyroxine, and we've increased the dose of thyroxine sufficiently to actually make him thyrotoxic. He's got raised free T4 levels. He's got clinical features suggesting he's now bordering on toxic with the tremor and the borderline tachycardia. Something is not quite right in the results that we're seeing. So if we go back to our pattern of TFTs and actually just now consider what are the possibilities that we might be facing. So initially, he presented in this lower quadrant on the left, where we had free T4, free T3 in the normal range with the TSH raised. And actually, by the end of the time of the titration, he'd moved over to this quadrant where the free T4 and free T3 were also raised, but where the actual TSH was not fully suppressed. And so which of the conditions that are listed here could be potentially explaining? And some of these are obviously not likely to be the case. Well, in all honesty, it's unlikely if we start over here with the normal free hormones and TSH, which is the scenario the GP first encountered, that we're dealing with subclinical hypothyroidism. This is really not the picture, especially with free hormones, which are in the upper part of the reference range. Yes, it could possibly be poor compliance with thyroxine. It seems extremely unlikely we're dealing with malabsorption because the patient on not an excessive dose of thyroxine has been able to absorb sufficient to ultimately make him thyrotoxic. There are no drugs involved in here, such as amiodarone, but laboratory assay interference is possible. This is not the typical pattern of non-thyroidal illness, where, as you know, in most cases, the free T4, free T3 are actually towards the lower end, or indeed free T3 slightly subnormal in the reference range and TSH low. And it's not a picture for TSH resistance, certainly not in a patient presenting at this age. That would be very unusual with the track record and the history. What about over here? Well, again, this is unlikely to be, for example, genetic disorders such as familial dysalbuminemia, hypothyroxemia. Again, we've got thyroxine replacement therapy, in particular compliance. That comes up again here. We're not on amiodarone or heparin. We're clearly not in a patient with psychiatric illness or neonatal period. Could we be dealing with the development of a TSH secreting adenoma behind the scenes? You would have to be extremely unlucky, but it's not impossible. And then, of course, it's very unlikely we're dealing with genetic disorders, because we would have hoped that pattern of results would have been given away much earlier. So if we actually look at the results that we have and we think about which of these could potentially be in play, it's all about the issue of compliance with thyroxine or assay interference. And the compliance would have to be a patient who was manipulating and taking the thyroxine at certain times, but not at others. So in actual fact, before we set off on that pathway, we always go to the laboratory, and the answer fell out quite easily, because the same sample sent to the laboratory twice produced results which were comparable for free T4 and perfectly in keeping with the fact this patient was now thyrotoxic on a high dose of thyroxine trying to suppress what was a factitious TSH. This was not a true reading, because here, submitted to a separate independent assay, is the suppressed TSH one would have expected given the high T4 and the fact the patient had thyrotoxic features. So this is all about assay interference. And just to remind you, the TSH assay, classic sandwich assay, 2 antibodies. The TSH itself is the filling in the sandwich. There's an immobilizing capture antibody, a detection antibody with a signal attached to it. And this assay can be confounded in various ways. The presence of heterophilic antibodies or even anti-animal immunoglobulin antibodies floating in the patient's bloodstream could cross-link the antibodies in the assay to produce a readout, even though there is no TSH in the sandwich. So the sandwich is being held together by this interfering antibody. That's giving a false positive result. But similarly, the opposite can happen. We can have antibodies circulating in the system which are able to interfere with the formation of the sandwich, for example, by binding to either the capture, or it could be, not shown here, but it could be also the detection antibody. So again, this is going to give a result which is essentially a false low result. So when we need to sort this out, it's useful to understand what the laboratory can do for us. And there are several things they can do. One is they can do a simple dilution study. And most interfering antibodies, when we dilute, will produce unusual results. So here's a genuinely hypothyroid serum sample. We're diluting that 1 in 1, 1 in 2, 1 in 4, 1 in 8. As we do the dilution and multiply back by the dilution factor, it stays extremely robust. This is a very consistent result. But if you actually have a patient who has interference in the assay, so there's no true TSH there, you can see as you begin the dilution step by step, this becomes very susceptible to essentially falling apart. So essentially those antibody cross bridges dissociate, and that back multiplication no longer works. And this is a very strong signal that there is interference in the TSH assay. We could also do polyethylene glycol precipitation and essentially try to remove the interfering antibodies and then measure the TSH in the supernatant that's separated after centrifugation. Or, and this is not readily available in most centers, we could do gel filtration chromatography. And here are peaks coming off the column. Here is normal TSH from a control sample being eluted in a particular fraction of the off the column, whereas here we have TSH in a patient that has actually got immunoglobulin bound to this TSH coming off the column at a different point in time. So this is a different way, and this is actually particularly helpful for solving a different type of issue we're not going to discuss today called macro TSH. So this is probably the next most important set of slides I'm just going to run through quickly. To reevaluate the clinical history first and foremost is absolutely the critical first step when we face dealing with a patient with unusual anomalous TFTs. And I would strongly encourage you to think about these headers. Is there anything unusual about the age of the patient that I should think about? If it's a lady, do I need to think about pregnancy-related changes? Is this a patient on thyroxine, whereby the dynamics of the axis are often slightly different? Are there any confounding medications? Or could I be looking at a form of non-thyroidal illness? And I won't read through each of these individually, but apologies, just going back, but these are all published and readily accessible in this article, which is open for everybody to see. So it's worth asking yourself the questions of all of these. And here are just some examples of why these are important. So age-specific reference ranges, for example, for TSH. We know that as we age, the reference range for TSH is probably not correct as published by most laboratories. So here's elegant data showing individuals from a large population who have a TSH more than 4.5, but with negative thyroid antibodies, normal T4 and T3, not known to have any risk factor for thyroid disease. Well, by the time we get to 70 years of age, at least 6% of the population have a TSH more than 4.5. And by the time we reach 80 years, that's more than 10%. So we probably need to adjust our laboratory reference ranges, for example, for TSH for age. We also need to think about how the reference ranges change, for example, in pregnancy. And people will be very familiar with the fact that total T4 reference ranges are very different in pregnancy. But also, we really should have slightly different reference ranges, for example, for free T4, and also trimester-specific reference ranges for TSH. Again, I don't have time today to talk about this in any detail, but I'll direct you again to this article. If you really think that you're dealing with a patient who is not concordant, compliant, whichever word you like to use with their medication versus malabsorption, it is important to have a very systematic approach to this so that you do not end up accusing the patient inadvertently of not taking their medication when there is, for example, something interfering with the absorption. And this can be very interesting factors, such as even, for example, your morning coffee. If you take a double espresso in the morning with your thyroxine, you can significantly interfere with the absorption. Of course, we're much more familiar with other commonly prescribed medications, such as iron replacement therapy or calcium-containing preparations. But there's a whole other string of disorders that can factors that can interfere with thyroid hormone absorption. And then also always think about other confounding medications, newly started medications, especially patients coming into hospital. And again, people in this audience will be very familiar with the concept that heparin, via activation of endothelial lipoprotein lipase, release of free fatty acids, and displacement of thyroid hormones, can cause essentially an in vitro artifact of raised free T4 levels. That means the patient's not thyrotoxic genuinely, but when you measure the free T4 level in the sample taken, if it is not transported rapidly to the laboratory, then you can see the free T4 level essentially raised as the thyroid hormone is displaced from the binding proteins in the tube where the blood sample is sitting. So they're just some examples, and therefore all of this needs to be done. We need to reassess the thyroid status of the patient, because when we talk to the laboratory, we need to be able to say to the laboratory, I think the patient's either hypo, U, or hyperthyroid, because that tells us which of the results is likely to be abnormal, and that in turn tells us whether we need to exclude thyroid hormone, i.e. T4 or T3 interference, or is it TSH assay interference. And only when all of those things have been done should you stop and start thinking about rare genetic or acquired disorders of the axis. Now I'm going to just show for the final minutes a few other cases which hopefully illustrate some important points that if you follow these principles, you are very likely to get to the correct answer at the end of the day. So these are briefer cases. So this is case number 2. Now, I'm not a pediatric endocrinologist. I suspect many people in the audience are, but we may be consulted sometimes by our pediatric colleagues because patients such as these are not so common in pediatric practice. Now, actually, this is a standard pediatric presentation because this is actually a patient in whom there was a question about early onset puberty. So this was a young girl at just 7 years of age who had actually had a menstrual bleed. And this had been happening for 4 days. She'd also had some progressive weight gain over the previous 6 months. Up to this point, there was nothing of note in her history, and she was taking no regular medications and no family history of note. When she was seen, she was noted to have dry skin, a slight bradycardia, a symmetrical goiter, and she'd certainly had entered puberty. She had Tanner stage 2 development. Now, this had triggered the investigations, and again, just to confirm, red is showing elevated results, and clearly for a 7-year-old, we wouldn't expect to see an estradiol level which is clearly inside the range expected during normal puberty. And from an axis perspective, we can see the FSH has been activated because there's an FSH of 7.9 units per litre, even though the LH at this stage remains low. In addition, some additional tests were requested, which showed the TSH was markedly elevated, the free T4 was low, and the prolactin was also slightly elevated. Now, we were not involved in the case at this stage, but our colleagues in pediatric endocrinology had arranged some imaging, and I became involved when the patient was actually referred to the pituitary MDT because of the findings on pituitary MRI. So apologies for the slightly grainy nature of these images. These were external films sent to us, but in essence, one can see that the cella is slightly expanded. There is clearly a lesion here expanding into the suprasellar area and actually compressing the optic chiasm. And we can see this on the contrast imaging much more clearly. And the chiasm is up here against the adjacent brain tissue. So at this point in time, I'd just like to get you all to think again for a moment about what you would do if you were faced with this patient referred to your service in whom there's a concern about further visual loss. Are you going to recommend at this stage that the patient be treated with dopamine agonist? Should we think about radiotherapy, somatostatin analog, thyroxine, or transsphenoidal surgery? Well, this is a talk about complex TFTs, and the answer is actually thyroxine. And I'm sure a number of you, if not all of you, will have thought about this and thought, well, actually, look, first and foremost, this young lady has really quite profound primary hypothyroidism, markedly elevated TSH and free T4. And this appearance on the imaging is very typical of thyrotrophic hyperplasia. And in actual fact, this patient does not need any form of radical surgical intervention as referred to our MDT4. She simply needs her hypothyroxemia correcting. And in so doing, a rather dramatic reduction in the hyperplasia was seen shortly afterwards, and a return of the gonadotropes to the prepubertal levels. And actually, everything then settled down completely. So this is a complication and something to watch out for of profound hypothyroidism. In fact, if you image the cella of many people with profound hypothyroidism, you may see these results. You may see thyrotrophic hyperplasia. Briefly, another case. This is another pediatric case, but this could easily have been an adult presentation. A young child with abnormal thyroid function test discovered because of developmental issues, neonatal seizures. This is a child that was not initially thought to have thyroid problems, other than just for exclusion, but you can see the free T4, free T3 dramatically raised, the TSH low, although not fully suppressed. Here are the results over several days in the postnatal period and at month 2. You can see the free T4 is dramatically elevated on occasions, with a free T3 also raised, TSH not fully suppressed, and also raised TRAB theta. But here the parents are normal. The mum has never had thyroid disease. What is the underlying cause for this? Is this an unusual activating mutation of the TSH receptor? Is it somehow iatrogenic? Is this a form of non-thyroidal illness? Could it be one of the rare genetic disorders? Or could this be neonatal Graves due to transplacental passage of TRAB? Well, of course, the mother doesn't have Graves' disease and has an intact thyroid, so this would be almost inconceivable to imagine. And in fact, the presentation here is iatrogenic. And what I'm highlighting to you here is that when these samples were sent to a second laboratory, they were completely normal. Not only did the thyroid function test normalize, but the TRAB was not there either. And this is iatrogenic and due to biotin. And I'm sure many people have now come across biotin being used as a supplement over the counter, but it's also used in medicine for treating inborn errors of metabolism and in multiple sclerosis. And biotin is a core component of some of the assays that measure free thyroid hormones. So biotin allows the conjugation of the capture antibody to the streptavidin beads for immobilization. And then we have a competition for binding sites between native thyroxine and analog. But if actually free biotin in the patient's plasma gets in the way and interferes with the formation of these complexes, that means we get no recruitment of antibody, therefore no recruitment of the competing analog. And in essence, that makes the assay essentially read out as if the patient is thyrotoxic. Now we can get around this by using a non-biotin based assay or an assay where these antibodies are already immobilized to the beads, so there's no risk of the free biotin. And here's an interesting experiment where one of my colleagues took biotin for several days just to prove the fact that over those days we were able to cause, in one particular assay that's susceptible, a raised free T4 level. And if you really want fun, this can actually cause mayhem in many, many different assays, so you don't just have abnormal TFTs. So always ask about biotin use. Now, I'm mindful of the fact that we're coming very close to time, so I'll just very briefly share this case, because I think this is a relatively recent case which illustrates another interesting observation of a patient referred to us with a sizable goiter. And you can see that this young man had a very large right lobe, 82 mils, left lobe, 63 mils, not a lot else. And the question was, why has he developed a goiter? And then we discovered some extremely unusual thyroid function test results. Non-suppressed normal TSH, normal free T3, but very low free T4, negative antibodies. Nothing unusual in the laboratory, no confounding medications. I'll miss the question out in the interest of time. The question is, what produces this pattern of results? Well, we also added some additional measurements. We checked the reverse T3, which was very low. We checked thyroglobulin that was very high. And we also checked urinary iodine, which was very low. And this actually is iodine deficiency causing preferential production of T3 over T4. And actually, when we then supplemented this individual with iodine, we were able to correct, or at least put ourselves on the pathway. This is very early on in the iodine replacement, and this is a modest dose of iodine replacement to correcting those abnormal TFTs. You can see the T4 coming up with retention of T3 and TSH. So this is a protective mechanism to prevent until the last minute hypothyroidism in the face of iodine deficiency, and the goiter is shrinking. So I'm going to finish by just exhorting you to remember all the different pitfalls that can occur when we're measuring thyroid function tests and where it can go wrong, in the laboratory or post-laboratory. And if all else fails, always return to thinking about the patterns of or conditions that can cause the abnormal patterns of TFTs. At that point, I'm going to thank everybody who contributes to all the work that we do, and also acknowledge all those I work with and the funders, and say, please always feel free to contact us. We're happy to try and answer any queries at any stage. And I'll stop at that point and say thank you very much again for the very kind invitation to participate.
Thank you, Professor Gunnell. As always, it was quite an eloquent and fascinating talk, dwelling into the thyroid physiology. You mentioned about biotin interference in the assays, which we do come across. Is there any recommended time period for which the biotin or the vitamins need to be stopped? And is there a dose beyond which the assay interference, both with the thyroid functions as well as for the TRAB, TSH receptor antibody, it is found to be interfering?
Yeah, so they're good questions, Aaron. I think the long and short of it is, in all honesty, probably just the very low dose over-the-counter preparations probably for the most part don't cause a major problem in most assays, but there are case reports of them happening to some assays. So first thing to do is go back to your laboratory and find out, are you a biotin-based assay? And are you a biotin-based assay, or are any of your assays biotin-based and susceptible to interference by free biotin in the blood? If, however, you unfortunately are working with biotin assays and patients are taking biotin, which sometimes I have to say they're taking without telling you, they consider it a supplement or something they're going to use that's not even medicinal, then in actual fact, if you're suspicious about it, you need to ask them. And then probably if they abstain for 24 hours, you're probably going to be okay. You're probably going to get a result which will be meaningful at the end of that time. And that's the case for most of the assays which are biotin-based. If somebody's taking really, really high doses, and some of the patients, for example, with multiple sclerosis do this, then you may need to wait a little longer, 48 or 72 hours. But usually that's enough time to avoid the issue. Failing that, send it to a non-biotin-based laboratory assay to confirm or refute.
There's one more question from the audience. Do you ever consider treating with levothyroxine in a patient who you think has got a non-thyroid illness? Is there any indication?
So generally at the moment, I still don't do that. So what I normally do is try to avoid measuring the thyroid function test at all, of course, but you and I and everybody else gets invited to the party when somebody else has done the measurement for us. There is, at the moment, still, I don't think, sufficient evidence to indicate that actually there is benefit from treating non-thyroid illness with thyroid hormones. And there remains, as you know, some more older data now, which suggests that in certain situations that actually may even be detrimental to the patient. So for the most part, for non-thyroid illness, I try not to intervene. The only time I really measure endocrinology, of course, during illness is when you really think it's actually the cause of why the patient's unwell in the first place. But yeah, unfortunately, we get often invited to treat these non-thyroid illness cases, and I normally politely decline in most instances.
Great. One last question. I think the role of measuring reverse T3 in sorting out abnormal thyroid function tests. In which scenario would you consider that?
Okay, so another very good question. For the most part, you need to be sure if you're going to measure reverse T3 that you really have a robust assay that measures reverse T3. I'm afraid there have been historically a number of people offering assays which probably don't actually really measure what they say they're measuring. But let's assume for a moment you have got a robust reverse T3 assay. I would suggest that in most cases you don't need it. It's only a very small number of situations, and we haven't spoken today about those, but there are certain conditions, genetic conditions in particular, so forms of thyroid hormone resistance, thyroid hormone transport metabolism disorders, which actually produce differential values in RT3, which, if you like, contribute to the thyroid fingerprint, and therefore potentially a part of the diagnostic algorithm for these complex disorders. But if people are asking, should you measure reverse T3 when just giving somebody thyroxine, I would say actually no. You're almost cruising for trouble, because actually we don't have enough reference data to begin with to even begin to interpret it. And then when the patient says, haha, my reverse T3 is a bit higher than it should be, you have to give me more thyroxine, and the next thing is the TSH is suppressed, you've ended up in a very tricky position.
Great. Thank you very much for that wonderful talk and answering all our questions. And we always would like to have you back in our forum if time permits.
I look forward to it, and thank you really very much again. It's been a real pleasure to join you all, and I wish you the rest of a really great meeting.
Great. Thank you.
The next speaker, I would like to introduce Dr. Muthukumaran Jaipal. It's my pleasure to introduce my friend and the familiar face of Trendo, Dr. Muthukumaran Jaipal, who's a consultant endocrinologist and the managing director of ARCA Center for Hormone Health, Chennai. He has training at UK at Newcastle. He has a lot of experience in research, doing research at Newcastle, and he has been the honorary treasurer from
I think Dr. Dalapati got cut off there. We'll move on to the session, Dr. Muthukumar.
Can you let them share the slides, please? Let me share slides. Right. My apologies for that. Good evening, ladies and gentlemen, and respected chairpersons. My task for this evening is just to give you a broad overview of the thyroid myths and facts. And although we doctors always differ from myths and facts away from it, it's one of the most interesting topics from our patient's perspective. They're always attracted towards our internet myths and YouTube myths. And that's the way of expressing their concerns and anxieties in relation to the disease. So this fairly becomes more important when you think about from their side of things. And if you ever Googled anything about thyroid myths and facts, there are humpty number of stories from a middle-aged woman to a granny expressing their symptoms. And these are most popular among patients, saying that only middle-aged women get thyroid problems. Thyroid problems are best diagnosed by symptoms rather than measuring hormones. It's safer to treat thyroid disease just by iodine and not by prescription medicine. These are all common myths available with the lay public. And there are many more which I've listed down. What we're going to look at this evening is from the physician's perspective and how to explain to our patients what is important as well. I'm going to look into this talk in 5 topics. So the task for this is to consider the scientific evidence between iodization program or iodine status in thyroid autoimmunity, what the diet as a thing plays its role in thyroid disease as a whole, Should we measure TSH at all? And should Dr. Petros mentioned about treating subclinical disease, how careful we have to be. But there is a very small area which is evolving, where we need to treat our younger patients to prevent ischemic heart disease. And then last but finally not the least is about Wilson's syndrome. So we have gone through lots of iodization program in the last 2 to 3 decades, and there has been a concern that the World Health Organization has issued data that there are some countries where the iodization has had an impact, and we are moving from an iodine sufficient to an excessive state. So this has been a concern, and this has been proposed to alter things as a cause for autoimmunity. And this is something, data from the World Health Organization again, and as you can see, these brick red are over-iodized countries. And so you have to, there are some countries where iodization is already causing a problem and what we should do about it. And this is some more recent data where those excessively iodized countries are moving further ahead and have not corrected itself. And you're all aware that we have got iodine requirements from the WHO as well as the Institute of Medicine in the US, but 150 for a non-pregnant adult and 250 for a lactating and pregnant women should be more than adequate. Why do we need iodine at all? We have had intense education and scientific data telling us that iodine forms a part of the pathway of thyroid hormone thyroid hormone production. So iodine is a very, very important trace element. And most of the iodine, what we get is from the seawater, which evaporates and returns to the soil in the rain. So if you're living nearby the sea, then you're more iodine sufficient. And the major sources are seafood, fortified bread and milk also contains excessive iodine in some cases where due to iodine supplements used in the milk production and cleaning of the udder, which contains also iodine in most times. So I'm not going to go through this pathway, but we need iodine to manufacture thyroxine, and we're all sure about it. And that's the pathway just to explain to it. Before I talk about taking iodine, we all know that iodine is an integral part of our thyroxine production, and basically the fetus needs it. Otherwise, there is a lot of pregnancy complications. The neonate needs it to avoid goiter, hypothyroidism, and mental retardation. And even as childhood, you need good iodine levels to maintain your mental function. So there are multiple ways, and then you become an adult. You need to maintain your euthyroid status, and iodine causes a lot of havoc if they are high or low. And this is one slide which is from the past, and the left picture is one from Congo, where these are 4 siblings, 3 female women who are between 18 and 20, and this is how bad things are. And one male sibling who's taller, and the other ones 3 are suffering from cretinism, severe iodine deficiency disorder. And this is a little bit more common for our audience, where we have had goiters even in a country like India in the past due to iodine deficiency. So we want to maintain levels between 100 to 119, which we measure as urinary iodine in the system, which tells us about the optimal iodine status. Why do we get iodine exposure in our environment? In Asian countries like Korea and Japan, seaweed is a very, very popular food, which is especially high in coastal areas. In some countries like China, there are also high levels of iodine, which have been noted in the water. Some animal feeds, including grass or iodophore cleaners, can make the milk or milk products richer in iodine. So these are all other supplements or other food products which give you an excess from more than iodization programs. And then comes the non-dietary sources could also be problems, where you can get nutritional supplements, iodine ingestion as a treatment by alternative therapies, amiodarone, iodinated contrast agents, and so on. Is it a risk factor? There are many studies which have reported in bedside data which suggests that excessive iodine in the system can increase your risk factor for autoimmune diseases. And the data comes mainly from multiple animal models, where when they're fed with an excessive iodine, it's associated with thyroid autoimmunity. And there are particular mouse models which are prone for autoimmune thyroiditis, like the NOD mouse, which has been extensively studied for iodine-induced AIT, and administration of iodine accelerates the autoimmunity. And then what about the stimulation of the lymphocytic response? And in these particular animals as well, the MHC class 2 expression is clearly induced by iodine treatment in thyrocytes. But the question is whether this iodine replacement is a stimulant or a causative, whether it has a causative role is the question. So this is the various processes where iodine excess could potentially increase your T cell activity, increasing the inflammatory pathways through the ICAM molecule. But more studies, I've just collated this slide with all the scientific evidence I could gather, that there are several underlying mechanisms suggestive that it potentially aggravates certain pathways, but there has not been a causative role for iodine excess causing autoimmunity directly. So in a patient who has got a tendency towards thyroid autoimmune disease, iodine excess could precipitate the disease early rather than causing autoimmunity as a causative role by iodine excess. So the clue what we have to take from here is elderly population, pregnant women, and neonates, or those with previous iodine deficiency problems are more susceptible to these excessive iodine-induced disorders. So you have to be careful when you replace them. So in a nutshell, the iodine status of the community has to be monitored closely until we know whether this plays a vital role. So no causative role for autoimmunity due to iodine. So that's the summary of that iodine versus autoimmunity. What about, is there thyroid diet? This is a common question which every patient who walks into your office asks you. So when we talk about the thyroid diet, we also talk about goitrogens, and any substance that could potentially increase the thyroid gland or cause a goiter is called a goitrogen. And mostly we associate goitrogens with multiple cruciferous vegetables and soya products. So anything from the Brassica genus, including broccoli, cabbage, Brussels sprouts, all these kale, cauliflower, and bok choy are considered as cruciferous vegetables. And these contain lots of chemicals, glucosinolates, which produce other isocyanates which are associated with anti-cancerous properties. So these are very, very important to be part of our regular diet. But unfortunately, when they metabolize, they also form thiocyanates, which inhibit thyroid hormone synthesis. So eating cruciferous vegetables have got certainly many health benefits, including anti-cancerous properties. But there are some case studies which show that they can induce or exacerbate hypothyroidism. Let's have a look what it shows. So the studies mentioning that cruciferous vegetable intake necessarily adverse thyroid function are very, very limited. That I can find only 2 studies here. There was one which was a volunteer study where they injected about kale juices, commercial kale juice, twice a day for 7 days, which failed to alter any of the thyroid function, but the radioiodine uptake was reduced by 2.5% from their baseline value. So the thyroid function remained normal. There was one important case report which came across where a Chinese woman really consumed around 1 to 1.5 kgs of raw bok choy, which is like a type of mini cabbage used by Chinese in their soups and regular meals, which I'll put it on. So this is bok choy. This lady consumed about 1.5 kgs for many months before she developed myxedema coma. So this is one case report. Should we support stopping cabbage, or should we avoid goitrogens is a question. So this is where, from the studies which are available, there is nothing to say that cabbage on the regular quantities which is consumed on a day-to-day basis, especially in a country like India where cruciferous intake is minimum, there is no need for a recommendation to avoid cabbage or cauliflower. A well-balanced diet which includes cruciferous vegetable in reasonable amount is very, very safe. There is little evidence to suspect cruciferous vegetable consumption affecting thyroid health. So there is also no link between goitrogens as well as autoimmunity, which is more common problem in today's world. So you can advise your patients, in other words, to take limited quantities as long as they're not eating 3 meals a day of cabbage. It's not a problem at all. What does soya do to your thyroid function? And dietary soya products are very, very common in today's world. Soya milk, tofu, soya sauce. These contain a lot of isoflavones, which inhibit the action of thyroid peroxidase, which is required for thyroid hormone synthesis. So it has been proposed that regular intake of soya in euthyroid individuals or higher doses can affect the dosage requirements of a thyroid replacement. So in euthyroid individuals where iodine is replete or iodine levels are normal, there was no incidence that it could affect your serum thyroid function test. In patients with severe iodine deficiency or more than moderate iodine deficiency, your thyroid can affect, your soya products could affect your thyroid function. So that's one thing of note. So if somebody is very, very iodine insufficient, as Dr. Mark Gurnall was talking, then you might have to avoid soya products until they get replenished. Selenium is a very, very important micronutrient, and it's getting more and more exposures are needed for treatment in thyroid ophthalmopathy. And the daily requirement is said to be around 55 micrograms. And the richest daily sources of selenium are seafood and meats. They're also provided in breads and grains. But selenium supplementation has been considered as a marker or a reason to support prevention of autoimmune thyroid disease. So, and this has also been supportive evidence to suggest that if somebody has got Graves' ophthalmopathy, then they would benefit from a 6-month course of supplementation of selenium containing supplements. So the simple thing would be, if you're just worried about selenium, taking 1 Brazil nut a day should help you with the daily requirements. So you don't even need a multivitamin pill to replace selenium. So Brazil nuts are very, very rich in selenium. So that should be sufficient if you want to improve your thyroid health by taking selenium. So in summary, you can eat all vegetables in moderation, moderate quantities to be mixed with all other vegetables, and avoiding goitrogens on its own may not help you. We should maintain a good iodine-based diet, and the goitrogenic effect of these vegetables are very, very minuscule, especially after cooking or steaming. So in an Indian setting, these are rarely applied towards our daily intake of goitrogenic total. You can safely consume soya foods if the dietary iodine intake is adequate, which is almost our population's iodine levels are normal. Gluten-free diet is not at all, is advisable only for patients with coexisting celiac disease, but otherwise you don't need to advocate gluten-free diet as an option for treating thyroid autoimmune disease. I'm mentioning this because this has been mentioned in many of the alternate healers who advise a gluten-free diet for autoimmune thyroid disease. The third thing where we are coming to is, should we measure thyroid as a marker of thyroid dysfunction at all? And there has been a lot of arguments in the internet about this, saying that thyroid function only measures certain people's levels. There are a lot of fallacies in even measuring TSH. So from a scientific point of view, these tests are very, very adequate for measurements. As Professor Gurnall mentioned, that there are instances, very, very rarely we get false reports from our regular thyroid function monitoring. And this is the same data from the NHANES data, where Hollowell mentioned that a median TSH of the population is around 1.5 to 2. So this is where the data comes from. And there are certain factors which influence our TSH, including age, gender, iodine intake, which we have looked at in the past. But what I want to factor in today's talk is the upper limit of TSH has been a question of argument in the last 2 decades, whether we should reduce upper end to 2.5 or keep it at 4 and so on. As we all know, elevated TSH happens by age and gender. But the new data suggests that there are populations, like especially Indians and Chinese, have a higher TSH. So we need to be aware of this and don't overtreat our populations unnecessarily. So especially with the pregnancy thing, data changing, we need to be really, really aware of who we are treating and what we are treating. Just skip this slide. So to put things in a nutshell, to give, even after measuring treated patients, we only achieve a 60% euthyroid remission in our treated patients. This is data from the Colorado thyroid disease prevalence study. By measuring T4 and TSH, we then alter our thyroxine levels, and still there are about 40% yet to be treated correctly, and we only reach a 60% state. So we continue to measure TSH because symptoms on its own doesn't tell us what the levels of thyroxine are. Some people might be just really hypothyroid with no symptoms. Some people will have many symptoms with no dysfunction whatsoever. So measuring TSH still provides the utmost value in our patients. So where Dr. Petros was mentioning very clearly about subclinical disease and who to treat and what not to treat, but one topic where I would like to just get your attention is, there's been long-standing thought whether preclinical hypothyroidism is a risk factor for coronary artery disease. And the possible mechanism stated for this is dyslipidemia, cardiac dysfunction, hypertension, endothelial dysfunction, and hypercoagulability. This started from the Rotterdam heart disease study, where subclinical disease was estimated to have almost a 14% risk of atherosclerosis. Further meta-analysis on the same topic suggested that there was a big divide between younger people less than 60 and 74. I'll skip this due to time. And this data initially suggested that treating younger individuals with subclinical hypothyroidism reduced fatal and non-fatal cardiovascular events and reduced mortality. And this particular population was the ones who are younger than 65, and they definitely had a benefit. And this was the same from the UK General Practice Database. Unfortunately, these are all retrospective audits or studies, clearly, but the data is well proven. If you want to reduce ischemic heart disease risk, then probably the subclinical disease should be treated. But the new NEJM RCT suggested that it further sealed the data that older adults do not benefit from the same when they get treatment, but there is certainly a divide for younger patients. So all-cause mortality in younger patients are much, much better off if you treat these patients with thyroxine. So LT4 treatment in subclinical disease is associated with lower CV mortality and CV event rate in patients less than 70 years. This treatment was not associated with increased risk of AF, and mostly it has also got impact on mental health, pregnancy, and subfertility. And individualized plans have to be undertaken for CV risk reduction and dyslipidemia. This is my last but one case. So this is about Hashimoto's encephalopathy, which has been widely treated, and the causative role is the antithyroid peroxidase antibodies. So we all know that this is a textbook description, and the pathogenesis has not been elucidated yet. So there is a cause that it is considered as an autoimmune encephalopathy because of the high prevalence in females, fluctuating cause, and association with other autoimmune disorders. It presents with either seizures and speech problems, or there is a progressive onset of psychosis and followed by dementia. So these are two things, but these patients are supposed to be dramatically different and responsive to steroid therapy. So people advocate IV intravenous steroids or high strengths of methylprednisolone tapered over a period of months. But unfortunately, until today, there is no shared antigen which has been identified between the thyroid gland and the brain. The precise role of antithyroid antibodies in this condition is very, very unclear. The antithyroid antibody titers don't correlate with the severity of the disease. So this is popularly called as a myth that thyroid antibodies are so common in the population, and it is just a coincidence that this could be associated with this condition. A final case is about Wilson's syndrome, and this is a typical case where at least I have 2 or 3 walk-ins asking me whether I should go about this, what should I be doing about this. This is a 25-year-old air hostess, weight gain of 3 kgs in 6 months, not feeling normal since a diagnosis of hypothyroidism 3 years back. She currently takes 100 micrograms of thyroxine, and free T4 is plumb normal in the mid-normal range and a TSH of 2.8. So she doesn't have any clinical symptoms except for the weight gain. Thyroid hormone levels are normal. She thinks she has got Wilson's syndrome. So Wilson's syndrome is a syndrome described by Mr. Wilson in the US. He has suggested that it is an altered thermogenesis in mostly females with the poor conversion of your T4 to T3. So this is kind of but the American Thyroid Association has discounted this version and almost called it as a fake disease. So this is a popular thing among our young female patients, asking about this condition and asking for T3 replacement. So she would want a functional treatment rather than a chemical treatment, and she was inquiring about her amathyroid people. Amathyroid is just a pork extract, and there are lots of things available. We as physicians in India are not do not have much access towards this, but we can, in some patients who are not feeling right just on thyroxine, can use a combined T4 and T3 therapy, so that your endocrinologist will help you with that. And in some cases, it has improved cognitive mood in a small group of patients. So a trial of T3 therapy may be worthwhile in your young patients who are not feeling right. So what are functional treatments for your hypothyroidism? This is mostly alternative treatments available on the internet. A sugar-free diet, a low thyroid hormone diet is supposed to be due to low B12 levels. So replacing that will help your thyroid function. Thyroid function is associated with altered GI motility. We know that, but people predict that it causes bacterial overgrowth and causes chronic GI symptoms. So they've been given probiotics to deal with their autoimmune conditions. And there is the last but not the least, gluten-free diet is widely advocated for Hashimoto's thyroiditis and hypothyroidism. But unfortunately, the scientific evidence behind this is very, very limited. So what is quackery? How to spot it? So a lot of these sites tell you only part of the story. They promote nutritional insurance. As long as they stick to that particular diet, it will work. Plays on fears of chemicals. They would say everyone needs supplements, promise quick, dramatic, miraculous results, promote distrust on other therapies like thyroxine therapy, and they resist peer review. So you need to be really, somebody is offering promise immediate relief for success, you need to be wary, state that refuse to work with other healthcare providers. These are common points where you need to be aware. If somebody is doing quackery, these are the pointing markers. So in summary, iodine is an essential element, doesn't really plays a causative role in the development of ATD, but it may play a precipitating effect on early precipitation in some individuals. All vegetables can be recommended for your patients with autoimmune thyroid disease. The goitrogenic effect is very, very negligible of some of these vegetables we have discussed. Treatment of subclinical disease may benefit younger individuals with very high CV risk, and thyroxine therapy would remain the standard of care, and T3 replacement can be considered in a small proportion of individuals. Current functional thyroid treatments for thyroid dysfunction are not backed by adequate research evidence. Thank you so much for listening.
It was an excellent presentation, sir. Sorry, I missed your for introduction because there was a internet problem in my home.
Not a problem, Thalgati.
It was an excellent presentation. And any questions from the audience? I don't think there is any question from the nature. Another thing I just want to ask, sir, regarding the timing of collection. Many patients come with what time they should collect blood test, either in the before food or after food. The timing of collection. Just you could say a few words about that also.
From our point of view, the newer tests, we don't mention any timing of collection unless, as earlier somebody was mentioning, that if it is pregnancy, then it might alter the course of your TSH or diagnosis of subclinical disease. For patients on thyroxine therapy, we do a random collection. All we recommend is to avoid giving your, if at all you're measuring free T4, then give a couple of hours gap after you have taken your tablet. The TSH doesn't show any significant change which is relevant to clinical practice. So in our practice, we just do random testing most of the time for people who are on replacement therapy. So we don't recommend a fasting sample for patients of hypothyroidism or hyperthyroidism.
One of the other things, Dr. you mentioned is when we have adequate dietary intake of iodine, you mentioned that many of these factors will not interfere with the thyroid functions. But how can we be sure that we are taking adequate dietary intake of iodine? There is no way we measure on a regular basis.
We currently have we depend on the national data or the international data. Currently, we are fairly in the safe range that most of our country, especially South India, is surrounded by sea. We have a good seafood intake and the soil is well versed with iodine backed by the iodization program. So currently the data suggests that our iodine status is fairly normal, except in smaller pockets where there are hill stations or tribal areas. So when you look at the data, there is a suggestion that autoimmunity could be worsened, but there is no causative role yet. With our levels, we should be adequately protected, and we cannot really blame the iodine for the autoimmunity. Certainly, our goiters have come down dramatically after the iodization program. The mental retardation, cretinism, deaf mutes have come down significantly, and we don't see them at all. And those are the benefits of iodization program, which has been fairly adequate in our country. Thank you so much.
Yep, no other questions in the chat box. We close this session and move on to the next.